Hello, everybody. Welcome to our second episode of the event of the series of preparing for winter pharmacy-based vaccination strategies. Today, we're going to prepare for winter in the pharmacy-based vaccination strategy, and I'm happy to start as a moderator for this session. So I will be moderating this session. I'm introducing myself. My name is Luna Al-Bizri. I am the FIP HAMIS Health and Medicine Information Section Executive Committee member for Africa and Middle East. I'm also a community pharmacist and a lecturer at the universities in Lebanon. Today also, Ali Burak Salman, the FIP Membership Marketing Coordinator, will help me as a co-moderator. So some FIP rules and announcements. So this webinar will be recorded and live streamed via YouTube. The recording will be available at the FIP website. You can ask questions and our speakers and panelists will answer in the question and answer chat box. You are welcome to provide your feedback at the FIP webinars at fip.org. And if you're not already a member, we encourage you to be a member at FIP, and you can visit the FIP website to see all the privilege of being an FIP member. A quick acknowledgement, this webinar is sponsored through unconditional funding by Pfizer. So as I have said, our FIP new series, Advancing Pharmacy Practices in Vaccinations, focuses on critical aspects of vaccinations and aims to provide insight into three key topics to advance pharmacy-based vaccination services. This is the second episode, and it is about preparing for the winter, and we are focusing on preparing for vaccinations campaigns during the winter session. This includes discussions on adapting vaccination strategies for seasonal challenges and ensuring the availability of vaccine during this crucial period. I encourage you also to register for the last episode, episode 3, that is going to happen on the 14th of November 2023. So what is this episode objectives? First, to provide the pharmacy professionals with winter-ready vaccination strategies, to equip them with the knowledge and tools to adapt vaccination strategies for the unique challenges posed by the winter season, to help pharmacy professionals combat seasonal illnesses by offering insights and best practices for addressing the increased incidence of flu and cold cases during winter, with a focus on at-risk populations. Finally, the third objective is to enhance pharmacy-based vaccination services for seasonal preparedness through discussions on proactive measures and strategies to meet the challenges of winter. Now, I am really privileged to say that FIP message is to advance pharmacy profession. And FIP is really the home for everyone, everybody, for the pharmacy practitioners, for the scientists, and for the educators, all in one umbrella and leaving no one behind. We truly believe that we can have no pharmaceutical care without a pharmaceutical workforce. And of course, we can have no pharmaceutical care without a scientific foundation for the next decade. So I don't know, but I think and I believe that many of you are familiar with our roadmap to delivering the advancements of FIP through our 21st development goals. They are all interlinked and are all aligned with the United Nations Sustainable Development Goals. And these FIP development goals are the road for the transformation of the pharmacy and our profession. So they are really they are designed to help us and to help our member organizations and to help all pharmacists to really transform our health profession. We believe it is imperative to bring science, as we have said before in the slide before, the practice and the workforce and education together in one transformative framework for our members and the wider profession to clearly set out the goals for development for the next decade. Each of these goals that you are seeing on our slide is composed of practice, of science, and workforce elements. So for each workforce pharmacy development goals, we have three elements that are important for the practice, for the science, and for the workforce elements. Alongside each element is a set of tools and structures to facilitate and support the process of transformation. Today, we are focusing on one of the most important FIP development goals, the FIP development goals 16 about communicable diseases. It is really related to vaccination, and it is through really helping prevention, awareness, and educating people about vaccination, we can achieve this goal, this 16 development goals. So as I have said in the slide before, we have three elements to talk about. First one is the workforce and education element. So education and training infrastructures in place to develop a workforce prepared to deliver quality services around communicable and vector-borne disease. The second element is the practice element. So it is about strategies and people-centered professional services for the prevention, surveillance, management, and therapeutic optimizations of communicable and vector-borne disease. And finally, the last third element is the science element. It is about capacity to monitor and respond to communicable with innovative approaches for prevention and treatment. I invite you really to go and see what FIP has created. It is about a dedicated microsite on vaccinations. It is, go to the link, please, and visit this microsite. It is so exciting. It is so educative. It covers everything about vaccinations through different publications, through different events, through different references. So you can transform your practice, your education by visiting this microsite. Finally, we have created in at FIP different tools to help all policymakers, our organizations, member organizations, to help even the pharmacists and to give them tools to draw policy documents and statements. As you can see, these two are two references that can help really our member organizations and policymakers to establish pharmacy services and vaccination services in community and primary healthcare pharmacy settings. You can reach them through this website. So I handle it now to Ali. Ali, please introduce our panelists. Thank you.
Thank you so much, Luna. Hi, everyone. My name is Ali. I am FIP's membership marketing coordinator, and I am really privileged here to be introduced by Luna Bizri, the profession's legend. And I am also very happy to be introducing our great panelists to you. Today, we will start with Mr. Eric Jager, Lisa Nissen, Ilan Kreiser, and which will be followed by Anna Van Renen, and then Leticia Caligaris. So our first speaker is Eric Jager. Dr. Eric Jager is an associate professor of microbiology and chair of the Department of Allied Health Sciences at the Albany College of Pharmacy and Health Sciences. At ACPHS, Dr. Jager instructs several courses in the life sciences and serves as program director of the college's pre-pharmacy program. As a member of the college's Tech Family Center of Biopharmaceutical Education and Training, Dr. Yager is involved in student instructions and the development of vaccine workshops for workforce training. Dr. Yager has more than 20 years of experience in the areas of virology, immunology, antibody-based therapies, and vaccines. He received his PhD in biomedical science from the University of Albany and conducted extensive postdoctoral research at the Trudeau Institute and Albany Medical College. His research interests include immunosense, the virology and pathogenesis of enveloped human RNA viruses, and vaccine development. Dr. Yager has authored more than 25 peer-reviewed publications, has given invited talks at several regional and national scientific conferences, and has been interviewed by multiple national media outlets. Dr. Yager is also enthusiastic about educating the public on viruses and vaccines, as demonstrated by his continuing guest spot on Talk Radio to discuss the COVID-19 pandemic. Dr. Eric, the floor is yours.
Good day, everyone, and thank you, Luna and Ali, for kicking us off and in the introduction. And pleased and privileged to be part of this fantastic panel today. So I'll start again, as Ali mentioned, utilizing kind of my areas of expertise in immunology and virology. I just wanted to provide some immunological and virological considerations as we enter into this, or really are in our flu and cold season. So it's important, I think, to have that perspective, because we need to have information to share the importance of vaccines amongst our colleagues and amongst the individuals we serve in the community. This slide here just illustrates, again, kind of the changes that occur in our immune system. Now why focus on changes that occur? It's pretty clear from a wealth of clinical and experimental data that, again, antibodies and T cells are really what are important to protect us against these viruses that we'll be talking about today. So flu, COVID-19, and RSV. And it's known that the ability to mount a protective immune response against these viruses does change with age. So very early in life, from post-birth to early childhood, the immune system is still developing, much like a child going to school, right? The immune system is learning the ropes, learning about what the environment, what threats are. Now, as we go into adulthood, of course, our immune system becomes, I would say, maximal. Our ability to respond to threats and the ability to respond to vaccines is greatly increased. And as we transition into older age, which I frequently getting into myself, is the profound remodeling and decline in the immune system, and that term is immunosenescence. So again, we have to consider of our community members, the individuals that we're serving, that their ability to respond to different viruses in this flu and cold season, and their ability to respond to vaccines is going to differ. It's important to understand that. Next slide, please. So I'm going to focus in my portion here really just on COVID-19 and RSV. And the data slide here I wanted to show is just to illustrate, even though there's some fatigue of COVID, I mean, we've had this, pandemic, it doesn't seem to end, and there's some fatigue. It's important to understand that the COVID pandemic is not done with us. The virus is not done with us. This is some data provided by Moderna has produced as what's called a bench to practice dashboard, which I think has a readily available source of data for looking at the hospitalizations and cases, at least in the United States. And what this data here shows is, again, looking at 38 million healthcare records in the US throughout the 2021 and getting some data here for 2023, just a number of cases of infection and hospitalizations due to COVID. And again, just to briefly go through this slide here, on the left, you can see the number of, again, hospitalizations, ICU, ED visits, and urgent care visits. And just to illustrate again that the pandemic is still present, the virus is still present, still causing problems. If you look on the right hand of the slide at the different age groups, of course, our 65-year and older age group is still at a high risk for hospitalization, again, due in part to their differences in ability to respond to the virus, to respond to vaccines. But it should be noted, too, if you look at the colored in the bars here, that it's not just the 65 years and older that we're concerned. There are certainly hospitalizations that occur in individuals 18 to 49 and 50 to 64. So I think that's important to point out because, again, the pandemic, even though, again, fortunately, with the advent of our vaccines and therapies, we're not where we were when the pandemic first started. Again, it still is a virus that's circulating, causing problems. Next slide, please. Along with that, too, it's clear that there are certain groups that are at high risk for severe outcomes during COVID-19 infection. Again, data taken from that same set of medical records. And I'll just draw your attention to the blue bars in this slide, and you can see for individuals that have hypertension, an immunocompromised condition, diabetes, etc., in terms of the hospitalization, there's a higher proportion of individuals with these pre-existing conditions, these comorbidities. So with that, we have an understanding now as we enter into, again, the season where we need to vaccinate, not only for COVID, but for other viral infections, that there are individuals that are in an increased risk for severe outcomes. Those are the individuals we do want to target for vaccination. Next slide, please. So in terms of COVID-19 and the vaccines we have available, when the vaccines were first produced, again, a big sigh of relief, I think, globally. But again, we've come to appreciate that the protection of these vaccines offer, while initially strong, does wane over time. So kind of a busy data slide here, but I just wanted to highlight kind of the points here. And if you kind of transition next slide, I'll have a red box that'll appear. I'm just going to focus on the vaccine efficacy against hospitalization. So if you look here in the data set from the CDC, those individuals that received only the monovalent vaccine, so they went through their primary series, there's only a 20% efficacy or protection against hospitalization and 31% against critical illness. And if we look at the bivalent vaccine, so this data is prior to the availability of the newly available monovalent vaccine, this is the bivalent, you can see that shortly after receiving the booster vaccination, individuals without immunocompromise are 62% protected against hospitalization, 69% against critical illness, and it lasts for about, again, a 2-month period. But if you look through the data here going down the table, we go into the, again, past the 2-month period, getting closer to 4 months, and to go out more to 4 to 6 months, you can see that the protection does wane over time. Again, very effective vaccine initially, but it's important to understand that that level of protection does decrease over time. Now, it stays somewhat stable against critical illness. So I think that's something to stress, that, again, vaccine is still protective, but I just wanted to show this data to stress the point that it's important for individuals to stay up to date with their vaccines. Next slide, please. And next slide, please. There. And I think this data really hits home. As I mentioned, that individuals age 65 and older are really prone to these respiratory virus infections, including COVID-19. And this data just really supports that it's important to stay up to date with vaccines. Now, the top line there, that dotted line, is the unvaccinated individuals. This is the incidences of death per 100 individuals due to COVID-19 SARS-CoV-2 infection. You can see for both age groups here that those individuals that were unvaccinated were at an increased risk for severe disease and death due to the infection. Now, those bottom lines, the solid one is the individual that received their primary series. The line below that, the small dots, are those that received the updated bivalent booster. Again, this data is a bit dated, but I think it really hits home a point that, again, by staying up to date with the vaccines, those individuals at severe risk for severe outcomes. So those individuals 65 years and older, they're greatly protected against severe disease and, importantly, fatal outcomes due to COVID-19. Next slide, please. I think with that, too, we have to recall that the virus continues to evolve. And with that, the vaccines need to be updated. Unfortunately, the new vaccine that's available, the monovalent booster, does protect against the XBB.1.5 variants. Even though the virus still continues to evolve throughout the fall and winter season, the vaccine will protect us. We do have to watch to see uptake. Right now, only 4% of the US population has received the new shot, so much more needs to be done to communicate the benefits of this vaccine. Next slide, please. I'll just quickly go through in the time I have remaining RSV. And I just want to focus on that because it's a virus that in some cases people are unaware of, and that it does cause a significant health problem to children and our elderly. So this is very similar to the viruses that cause problems in winter. It's an envelope negative sense RNA virus that infects the airway cells. Most of us are infected by the age of 2, and even as adults. And again, most infections do tend to be mild, but individuals that are very young, so infants less than 6 months of age, adults over the age of 60, those that are immunocompromised can have severe outcomes. Next slide, please. Again, as I mentioned, in some cases, individuals are unaware that this virus exists. They're really focused in on influenza, COVID-19, and some other pathogens. But really, this is a virus that causes a large impact on public health. So the global healthcare costs are estimated to be $5.45 billion annually. Now, this is a seasonal virus typically. There have been some changes in circulation due to the pandemic, but still, again, children between the ages of 0 and 4, adults 65 years and older are at an increased risk for hospitalization. You see those rates have increased over the past a year or two for a variety of reasons. Part of it is due, I think, to some of the changes that took place due to the non-pharmaceutical interventions we needed to implement for the COVID-19 pandemic, and again, a falling rate of the protective measures. Next slide, please. So when we think about how to protect us against RSV, the two terms that are important to think about are active immunity and passive immunity. So active immunity is what we receive, or our own immune system responds to the virus or the vaccine and provides protection against that particular pathogen. Where passive immunization is a transfer of antibodies from typically one individual to another that gives us short-term protection. Next slide, please. So focus on the passive part for RSV. When we think about the virus, it is known that the virus's F-glycoprotein, that's an important protein that's important for the virus to get inside cells. Kind of think of the lock and key mechanism. If we're able to prevent that lock and key interaction from occurring, we can prevent infection, prevent severe outcomes. There is an existing monoclonal antibody, pembrolizumab, which was approved by the FDA in 1998, that does bind to the pre-fusion F protein form that the virus expresses prior to infection. And that does block the ability of the virus to enter cells. Now, it works quite well. It's been used in premature individuals for quite some time. But the difficulty is here that it doesn't bind to all the antigens present on the F protein to confer best protection. And this antibody must be delivered every 28 to 30 days during the RSV season. Next slide, please. Next slide, please. So there's at least in the US, a newer monoclonal available, nirsevimab. And this one is a monoclonal that binds to multiple sites. And if you hit next slide, please, I can illustrate the binding sites for this antibody. It binds more broadly for that pre-fusion F protein that I mentioned that is now able to confer better protection, better neutralization. And this antibody, it's been modified, having a longer half-life. So both its improved efficacy, you can see here the data on the slide, 70 to 78% protection against RSV-attended lower respiratory tract infection in infants, and that the antibody can be delivered once and it should last throughout the RSV season. And importantly, this was recently approved by the FDA. I believe it was approved in 2022 by the European Union. But this now is a other weapon in our arsenal to protect those young adults, young children, from RSV. Next slide, please. And next slide, please. Now, in addition to that passive immunization from a monoclonal antibody, another way to protect our developing infants and after birth is through maternal antibodies. And again, we don't have time to go through the the full immunology lecture I would give to my class, but I think it's important to appreciate that if we are able to vaccinate mom, the antibody that moms produce are able to pass through the placenta to protect the developing child. So both the IgG that's produced protects the child, and of course the IgA the mother is producing can be delivered to the child through breast milk. So again, another form of passive immunization is going to protect the child, again, both during pregnancy and after delivery. And just again, you can see here that the amount of antibodies present in fetal blood increase dramatically as we get closer and closer to delivery. So it's very important to have approaches that confer protection in that child, that it gives that child time, their immune system to develop to have their own protection. Next slide, please. So fortunately, we now have a vaccine, actually two, available against RSV. I'm just going to focus on the Abruzvo vaccine. Again, fortuitously being sponsored by Pfizer here, but focus on this vaccine because it has utility in both older adults and young children. So just to briefly review the data that supported its approval by the FDA earlier this summer, is there was the Renoir study, and this showed that vaccination against RSV, and this vaccine is targeting, again, that F-glycoprotein that's important for the virus to gain access to cells, that a single dose given intramuscularly protects older adults from severe outcomes to RSV. As I mentioned in the beginning, very young, very old are those key populations we look for with these winter viruses. So this vaccine data supports that it has an efficacy of 99% against lower respiratory tract disease, more severe forms of disease, that lasts through the season. And data is still being collected, but it appears that that protection is durable through a second season. So now we have an approach, an immunization approach, an active immunity approach to protect our older adults. Well, what about our mothers and children for passive immunization? Next slide, please. And with the, back one, sorry. And with the same, nope, you're right, sorry. sorry, go ahead one slide. Go ahead a second slide. Sorry about that. So there was a second study performed by Pfizer called the Matisse study. Here they used the same vaccine in individuals that were pregnant. They were vaccinated and then they were followed through pregnancy, followed through post-birth. And what this data fantastically shows is that, again, the level of protection in the children born of mothers that received the vaccine was high. So you can see here in the data was approximately, in here, almost 82% effective at preventing severe lower respiratory tract disease caused by RSV in young children 3 months after birth, and it lasted upwards of almost 70% 6 months after birth. And because of this data and its safety profile, the FDA recently approved this vaccine to protect infants through 6 months of life. I believe it's received approval for the European Union as well. So now we have multiple, again, weapons in our arsenal to protect the very old and the very young from RSV, be it through vaccination for our older individuals and really passive immunization for our children, both with the monoclonal antibodies and our vaccines. Again, so just to sum up my portion here, and sorry for running a bit over, again, is that we do have to consider the age of our individuals that we're looking to vaccinate, that their susceptibility to these winter flus and colds need to be recognized. And with that, we have newer tools available to protect them. Thank you for your attention. I'm happy to take questions in the chat. And I'll turn it over to Lisa.
Thank you so much, Eric, for this amazing presentation. I already took a lot of notes, and I would definitely like to join your full class if I had the chance as a colleague. So our next valuable speaker is Lisa Neeson. Professor Lisa Neeson is Program Director for Health Workforce Optimization, Center for Business and Economics of Health, University of Queensland. She has been a health practitioner, leader, educator, researcher, and implementation scientist in Australia for more than 25 years. Lisa's research has led to major health system change, including the introduction of immunization services by pharmacists throughout Australia and implementation of prescribing competencies and frameworks for health professionals nationally. More recently, she led a Queensland team who implemented pharmacist treatment for uncomplicated urinary tract infections. Her focus is on health service optimization, including scope of practice and quality use of medicines. She is a fellow of both the Society of Hospital Pharmacists of Australia and the Pharmaceutical Society of Australia. As impressive as always, Lisa, the floor is yours.
Thank you very much, and thank you very much to FIP for having me here this evening/morning, depending where you are in the world. And it's always a tough act to follow somebody who's an immunologist. So luckily, I'm not talking to you specifically about vaccines per se, but I think there's some really great messages that we can take away from Eric's presentation coming into what I want to talk to you about today, which is some things around the circulating viruses and the fact that they literally do circulate. And I'm coming to you from Australia, having just finished our flu season. So you're preparing for winter, but we've had winter, and it's 35 degrees Celsius here, and it's well and truly summer. The idea that we have people that are at risk, and we think very much about people that are at risk for chronic disease and chronic illnesses, but we have an emerging consideration very much, I think, born out of our experiences during COVID. And I think Eric spoke really well about this around, I guess, what used to be considered, particularly in pharmacy and primary care, the worried well or the working well. And it was, I think, for a lot of our jurisdictional leaders, it was a group that, you can vaccinate them if you want, if they get a vax, within their workplace. That's all well and good, but I think adult vaccination generally has been a bit of a lost space in vaccines, but I think it's risen in its interests and considerations broadly now because of COVID, and that is a group, the working well, or what was considered the worried well for vaccination, and we've certainly seen that here in Australia. I think the value of seasonal vaccinations, and I think Eric spoke very clearly about that, and I'm going to touch on some of those things in what I speak about today. And the fact that we've now got a range of vaccines across age groups, not just for influenza or flu vax, but an emerging group of vaccinations coming. So I think there's a nice segue into what I want to talk to you about today. So I want to cover three main sections today, because when we talk about preparing, and in the context of some of the things, lessons learned and things I can talk to about the Australian context, have to really give a bit of a vax journey from Australia to sort of talk about how we were in the position for our current flu season and winter vaccination season, some of the data and experience that we've had just recently from that season, and some of the lessons and strategies to take away. Next slide, please. So just to start off, I want to talk about how we got to the point of being able to vaccinate millions of Australians now for influenza particularly, and other vaccines within community pharmacy in Australia. So next slide, thank you. So our vaccination journey, and I think we've had a number of great resources developed and webinars and other learning sessions throughout a number of conferences and presentations like this, and tools that have sort of given resources to countries and emerging jurisdictions wanting to get into the vaccination space. But our journey started almost 10 years ago, where we piloted vaccination in one jurisdiction, which is where I'm from, in Queensland, where we started influenza vaccines in a small pilot. And that was something which, if we go to the next slide, in a very short period of time, using the evidence from that pilot and being able to use that across the other parts of the country, we were able to be in a position after the pandemic, but before the pandemic as well, where not only influenza, but a wide range of other vaccinations were available. And we positioned pharmacy vaccination in the country to be one of the leading providers of COVID vaccines. So that puts us in a good position, not only for winter vaccination, but also the provision, as you can see, of other vaccines like our ACWY, DTP, meningococcal, and a range of expanding vaccinations. And I'll talk to you about how this is now a wider range even further. Next, thank you. So there was a strategy that came with this that has now meant that we have an expanded range of childhood and adult vaccinations available in the country, which means that not only do we have access to a wider range, but they are now funded. And so previously, this whole idea of worried well meant that it was a fee-for-service service in pharmacies, which meant that if you wanted to come into a pharmacy to get a vaccination, you had to pay out of pocket to do so. And plenty of people did, because it's about being able to get the right service at the right time for you. So many people were happy to do so. But now, because of that, the government is happy to pay pharmacists to provide these vaccination services, and that will start at the beginning of next year. Many of our jurisdictions, like the one I live in, have already begun to acknowledge the value of paying for people who come from chronic disease, pregnancy, lower socioeconomic groups, being able to have that ability to access services when they need them. And now there is a groundswell, particularly for our seasonal winter vaccines, for free flu vax for everybody. So that is now something that we are seeing across the whole country as a response. Next slide, thank you. So some of the current data on our numbers. So what do our vaccination numbers look for this season, but also how that compares over the last couple of years, understanding that we've had COVID, and we've also had in a mix of that some tough flu seasons, and we've had probably more deaths related to influenza in the last couple of years than we've had in the preceding years. Not just because of COVID, but because the flu seasons have been more aggressive, and we've also had some combinations of RSV, COVID and influenza circulating concurrently. Next slide, thank you. So if we look at COVID vaccinations themselves, not unlike other countries, we had a very rapid uptake of COVID vaccination by pharmacists once we were able to administer them. So this was in the community. You can see at the bottom left-hand corner of the slide, that was when we started to have vaccination back in the middle of 2021, which upticked extremely fast over a 12-month period. Right up to now in 2023, although that's flattened out and plateaued, we are still delivering probably in Australia, the majority of COVID vaccinations that are delivered in primary care are through community pharmacy. So that's the box over on the right-hand side of the screen. So if you are looking to get a COVID vaccination in primary care, it will generally be something that would be delivered through a community pharmacy. Our general practice colleagues are not really administering them anymore in most of our Australian jurisdictions. Next slide, thank you. So if we look at next slide if you can. Might be a bit of a lag. So if you look at our influenza vaccinations in pharmacy, and this is actually 2020 to 23, that's my mistake, sorry. You can see that there's been an increasing proportion, which is the green bar at the top, of vaccinations delivered by pharmacy for flu. And so we're now up to, in the last 2 flu seasons, around 25% of vaccinations across the country are delivered by pharmacy. And that's quite an interesting statistic now when you acknowledge that a lot of that is fee for service, in that patients are paying for those vaccines out of their pocket. So it'll be interesting to see as the nationally funded vaccination services become available, whether we see that proportion increase over the next year or two as that service comes in. So if we go to the next slide, you'll see what that looks like as a proportion of vaccines, and this will give an indicator of what our vaccinations have been like over the last couple of years. And not surprisingly, probably similarly to your own countries, everybody got vaccinated for flu last year. And I mean that as a very broad statement, but there's definitely an uptick in flu vax last year. And certainly having COVID circulating and other respiratory illnesses meant that people had vaccination on their mind. And many jurisdictions are now considering that there is vaccine fatigue. And I know that there's been fit discussions and seminars around hesitancy and engagement in vaccination post-COVID, and how we maintain community confidence in vaccination. And that's something that's certainly happening in Australia as well. So at the moment in 2023, we've delivered over 2 million flu vaxes through community pharmacies this year. Next slide, please. So what does that mean in the context of our winter? As I've said, it's 35 degrees here, so I wouldn't really say that it's winter. But what this curve speaks to is that generally our season would be considered to peak probably around the beginning of August. But we generally start vaccinating for our flu season around the end of March, early April. So around Easter, with our peak vaccinations happening around the middle of the year and then starting to tail off. But that's our standard sort of flu curve. Next, please. So why is this something that we've had to think about? So next slide, please. What we needed to do was prepare our workforce broadly for vaccination, but we knew that as we started to increase an interest and a demand for vaccination community pharmacy, it couldn't be an artifact of people turning up at a pharmacy and not being able to get it at that pharmacy. So if we were going to have vaccination in pharmacies, it needed to be any pharmacy that people arrived at needed to be able to have a flu service available. It also meant that you needed to have all staff on board for the VAX program for implementation, which means your assistants, technicians, your front of store staff. So anybody that was in the pharmacy had to be on board with the service provision. So there needed to be an implementation and VAX program service. So next slide, please. So part of that from the get-go was the training that we implemented way back when we did the pilot in 2014, which formed the basis of the national training program for pharmacists in Australia. And that was delivered against national immunisation competencies for all health professionals. So that meant that we had a framework that was acknowledged across multiple professions. We weren't asking for something different. We were asking to be assessed across similar competencies. So if we go to the next slide, we'll see what that gap looked like or was considered for pharmacy. And not surprisingly, the real gaps weren't about cold chain and immunity, although certainly most of us wouldn't conceive of having the same depth of knowledge as Eric. But we had a good understanding of vaccines, anaphylaxis, vax schedules, etc. But we really needed to understand administration of vaccines, patient assessment, declining patients, and managing a vaccine service. And so that's really where this training was centred. Next slide, please. And so we went on to develop a framework that enabled us to prepare not only pharmacists that were participating in the pilot and then prospectively pharmacists going around not only my jurisdiction but the rest of the country, but we were able to train our students so that as students left university, they were able to vaccinate, and they could vaccinate while they were still at university. So that meant working with regulators to ensure they could do that under supervision as students. But now it means that in Australia, we have about 80% of pharmacists identify as being able to vaccinate, meaning that when we come to providing our winter flu service, particularly in our community pharmacies and in a lot of our hospitals, they can vaccinate in high-risk outpatient services, but in community, you can go into pharmacies and you can get vaccination services when you walk in the door. Next, please. So the other part of that is about optimising the ease of access. So in preparation for that, most of our community pharmacies use booking services. And they use booking services not only for influenza and COVID and other vaccination services, but they use booking services broadly for other things that they offer in their pharmacies. But particularly this is utilised during our winter vaccination and flu season. And certainly during COVID. And you can see on the left-hand side of the screen, I've selected that I can get a flu vaccination. I could also select that I want COVID and flu at the same time. I can pick the type of thing that I want, if I want a flu vax or I want to combine, Pfizer vax and a flu vax. And then I can pick when I want to get it and where I want to get it. And what this means is they can not only raise awareness because they advertise that this is available early for people to book in early to get their vaccination. It optimises their workflow and their planning. It allows them to prepare their workforce for likely workflow that they might have to consider, other staff planning that they might have to do around the amount of people in the actual pharmacies. But it also allows them to plan for walk-in options and a booking system to be running in parallel. And pharmacies, particularly that are co-located near medical centres or near other practices close by that are providing vaccination, like general practitioners, will work on planning these kind of things strategically so that they can cross-refer patients. So if there are chronic disease patients that would benefit from being referred through to the general practitioners to have their vaccinations, and GPs have people that would benefit from getting a quick vaccination from the pharmacy next door, they will cross-refer. And what we've found evidence from is that all ships rise. So vaccination rates in both places rise by working together rather than fighting with each other about who's vaccinating who. Next slide, please. Other awareness raising activities are things like this kind of campaign, utilising that idea that we vaccinate across age groups. So this isn't just targeting the adult vaccination, but it's talking about protecting the family. And so because we can vaccinate from 6 months and up as our scope of practice, we can do flu vaxes that are available for 2 years and up. And so instead of having to go to the doctors over here to get your flu vaccination for your kids and over here to come and get your own, pharmacies are now saying that you can come and do all of us at once, and it becomes convenient and access is less of a problem. So you can link all your bookings to that booking site and get it all done in one. So it's very much about don't hesitate, get it now, you know, try and facilitate things as quick as possible. Next, please. We've also been able to link through to a lot of the national, state, and local campaigns around flu vaccination. And so it's been important that the pharmacy profession and pharmacies themselves have aligned with those campaigns, and these are some examples. And you can see that the pharmacies very much are aligning to the quick, convenient, walk in, come and see a pharmacist where they're experts to get your shots. Next slide, please. One of the things that the pharmacies do use quite strategically is many of them have a patient application. And so this is an example of one of the Terry White Chemmart apps, and many pharmacy groups will have them, where they use them not only for customer loyalty, but it's a medication management and dose assisting app. So it will allow people to trigger script renewals, but it will also help them with compliance or medication assistance. But they can also book directly through the app for a vaccination service. So they can use these also to raise awareness and say flu season's coming. Grace, you know, you are eligible for a flu vax, or you should come in for your flu vax because you had one last year. Come back in and get another flu vaccination. So people are strategically targeting people that are within their system to come back for reminders, or people that are eligible for particular vaccines. Next, please. So the take-home messages really are that we strategically built workforce capacity to make sure that if we said we could do something, we could do it, and we could do it across the community pharmacy space, particularly training students as our proactive attempt to increase workforce capacity. And over that 10-year period that we've had this in place, we now have done that. Pretty much people who want to vaccinate have opted into vaccination. We have a track record of success because we were very successful, particularly with flu and COVID. It's sort of unleashed the floodgates for pharmacy to have access to all nationally funded vaccines. We have lobbied for an expansion over that 10-year time period of age groups and for funding, and that's enabled us within the context particularly of the winter campaign to do all ages and varying groups, and to provide increased access by having funding to do so. Within pharmacies and within the community area, targeting and consolidating staff approaches in store to make sure that we are getting the right people, as Eric pointed out, that will benefit particularly from having vaccination, and speaking as a consolidated voice about the benefits of vaccination within those groups. Linking to the national strategies and community campaigns, using booking systems, particularly targeting at-risk patients, and working in sync with other local vax providers have been some of the key strategies within the Australian system during the last vax season. So hopefully that's of some assistance. I'm happy to hand over to our next speaker. Thank you.
Thank you so much, Lisa, for this amazing presentation. And we already started to get some questions on the Q&A box. We encourage our other participants to ask their questions using the Q&A box. So without any further ado, I would like to go to our next speaker, Ilan Kreiser. Ilan graduated from the School of Pharmacy at the Hebrew University of Jerusalem in 1984. He completed his MBA in Heriot-Watt University in Edinburgh between 2000 and 2001. He was the first chairman of the Pharmaceutical Society of Israel, and he worked in between 1997 and 2001. He was also the IPSF Secretary General between 1985 and 1988. He is the co-founder and the first chairman of the previous YPG and now ECPG. That was between 1993 and 1998. He's a community pharmacist for his entire career, and he's a pharmacy owner. And he is the only vaccinating pharmacist in Israel. Ilan, the floor is yours. We're waiting for your presentation. Can you hear us, Ilan?
I can't seem to.
Now we can hear you.
Do you see me as well?
Yes, we see you. Thank you.
Okay, great. Well, thank you, Luna, and thank you, Ali, for that introduction. I also want to thank FIP for inviting me. I am also the Israeli liaison officer for international affairs, linking me with FIP, and as such, I returned just about a month ago from this year's FIP conference in Brisbane, and I've got to tell you all that was an amazing meeting, both professionally and socially. I spent a lot of time discussing pharmacy with colleagues from all over the world. Today's topic was something I discussed with a lot of people, being very close to my heart, and following Lisa's presentation, you can understand why I came home very, very jealous. So, to today's topic, no conflict of interests. Next slide, please. Anyone who's seen Game of Thrones knows that winter is definitely coming. For most people, that just means getting your ski vacations booked and perhaps cleaning the leaves off the roof of your house. But for health professionals in general, and pharmacists involved in particular, that means getting yourself prepared to do everything you possibly can to help our patients. And as a community pharmacist, I see this an awful lot through all the winter problems. And influenza, now COVID as well, but influenza is a great one, and it's something we can do very much about. Next slide, please. The recommendation in Israel in general is vaccinating the entire population, but special attention is given to the elderly over the age of 65 who show the highest risk, and to kids 6 months to 6 years old who are considered to be the primary culprit in influenza transfer from person to person. So at the early September, we start a campaign targeted towards these, mostly these, both nationally by the Ministry of Health and by individual pharmacies, just to start talking about flu shots, start reminding and stressing to people to get their flu shots. Most brands of vaccines are available, and the interesting thing now is the high-dose quadrivalent vaccine, which is also available. However, it's not covered by insurance, and a lot of people are just not it's not available to them. It's primarily limited to chronically ill and elderly people. So let's see a little bit of numbers from last year, because flu season is not yet totally here yet. 58% of the elderly got flu shots last year. When we look at 75 years and over, that reached 63%. Now that might sound okay, whether impressive more or less, but if we look at the entire population, we only reach about 25% of the population getting immunized. Males were 31% more likely to get vaccinated. That surprises me. Healthier people are less likely to get vaccinated, which kind of makes sense. People with higher education were also less likely to get vaccinated. Again, a surprise. And people with higher income were more likely to get vaccinated. This is numbers from Israel, and these are things we can work with behind the counter, talking to people, especially if we realize what age group or what demographic they belong to. Next slide, please. We're a Northern Hemisphere country, so immunization season is just like the rest of the Northern Hemisphere. Starting in September, that's when we begin immunizing and hopefully reaching maximal potential by December. But flu shots are still available even later. Now, in 2017, the Epidemiological Division of the Ministry of Health decided to recognize the fact that we're not getting the job done the way we probably could, and look for another way. Seeing that pharmacists have become a source of vaccinations in other parts of the world, a law was passed allowing pharmacists to perform influenza only, at this point, vaccine in Israel, under certain conditions, which I'll touch upon a bit later. However, that new law opened a can of worms with allied health professionals, at least some of them, not very happy about it, perhaps a turf war, perhaps feeling threatened by pharmacists taking part of their jobs away, mostly nurses. This led to the regulations that were enacted following the law being very difficult, being hard for pharmacists to comply with. Today, 6 years later, only a small percentage of the population are being vaccinated in pharmacies. And as Ali mentioned at the beginning, I today am the only vaccinating pharmacist in Israel, something I really hope will change. Next slide, please. What you can see here, this is in my pharmacy, is the immunization room. I promise you the door opens more than that. But the room itself, while again understandable, is one of the problems that more and more pharmacists should be getting involved in. Next slide. What we need to do when flu season is on the way is, and if we want to immunize, is we need that immunization room that you've just seen that's at least 6 square meters in size with running water. Considering that most pharmacies in Israel are 70 to 80 meters with 30 meters behind the counter, giving 6 meters for an immunization room is something that not many pharmacists can allow themselves to do. Within the room, we need the couch that you saw before. We need chairs for patients to rest on after their shot. We need epinephrine ampules or the automatic EpiPens in case of allergic reactions, anaphylaxis. Even though that's very rare, we need to be prepared. We need containers to dispose of sharps, and we need to be able to provide medication records because they need to be transferred to the Ministry of Health, and they need to be transferred to health insurance plans. Now, considering that flu shots are considered a quality quotient in Israel, there is definitely a financial incentive to all these to get as much flu shots done as possible. Still not working to the best of what I believe to be our ability. Also, at pharmacy level, we need to pre-order our flu shots. This is generally done in May or June before the flu season. And we have to clear out space in our refrigerators to be ready for whatever needs to come in. Next slide, please. What we're allowed to do is kind of difficult. We're only allowed to immunize people over the age of 18. We're only allowed to immunize individuals who are not asthmatic, who've never had side effects from a previous flu shot, are not allergic to eggs. Okay, that's a known problem, and who don't have fever at the time that we immunize. Now, this also is a difficult issue because the people under 18 years old and the asthmatics are probably the groups of people who need to be immunized most. Now, I do understand that there might be some benefit from additional medical supervision, but pharmacists can surely, with their training, be able to handle whatever might happen to these people. Next slide, please. Pharmacists are the most accessible health personnel. We all know this. There are pharmacies at every other street. And we can make life a lot easier for our patients and have a very useful role when it comes to immunizing against flu. Problems are that this role has got to be acceptable to the health system, which, especially in Israel, well, not especially, but in Israel, and I imagine in other countries as well, is not always the case. Surprisingly, pharmacists themselves don't always see themselves wanting to immunize. And it's up to us, the pharmacists who have spearheaded this and the national organizations, to try and drive this forward opposite our health systems and opposite our members themselves. So influenza vaccines have to be ordered ahead of time because we'll be stuck without if not. Space needs to be cleared out. A campaign towards the population we need to vaccinate most, children and the elderly, must be held again starting in early September, whether by talking from behind the counter or by sending out notices, using social media now, all these being done, but again, not reaching everyone we need to. We need to refresh our knowledge. Don't forget, we only really deal with flu 3 or 4 months a year. The rest of the year, not. So we have to refresh our knowledge, especially now with COVID coming in alongside. People are asking questions, and we need to know how to answer them, both regarding flu, COVID, and the combination of the two. We also need to refresh our techniques. We don't want to hurt our people. And I know from being a young immunizing pharmacist a few years ago, that's possible. So we need to practice either using a rubber ball or using an orange, which also makes it kind of fun. Next slide, please. We have a lot to do. We can do a lot. And patients can benefit from having their pharmacist and immunizer. So let's work on this all together. Let's have a great winter, and let's make the difference that I know that we can. Thanks very much.
Thank you so much, Ilan. Now we're moving on to our next speaker, Anna van Rennen. Anna joined the ILC, the UK's leading authority on the impact of longevity society, in 2023. She works in health and social research, and current projects include preventative healthcare, vaccination, and continuous education in older adults. Anna is from the UK, but lived and studied in South Africa for 10 years. Aside from the ILC, she is still conducting research through the University of the Witwatersrand in Johannesburg on access to pediatric healthcare for migrants. Living, studying, and researching in South Africa for a total of 10 years allowed Anna to develop a deeper understanding of inequalities and disparities often found in the healthcare policy and practice. Because of this, her passion lies in how policy can promote equitable and inclusive access to social and healthcare services, and how inequalities can be addressed to ensure institutions provide longevity-based healthcare and social services to everyone. Dear Anna, we're happy to listen to you.
Thank you so much, and thank you so much for having me here at this webinar. It's been really interesting to hear what everyone's said so far. So, as Ali said, my specialization is policy, so I'll be looking at vaccination from more of a policy perspective. If we could go to the next slide. So just for some context, I'll be talking about flu, COVID, and pneumococcal vaccination. I know pneumococcal isn't technically a seasonal vaccine, but because it's recommended that if you don't have it already, you should get it in the months coming up to autumn and winter, I've included it in this presentation. As we sort of get influenza and our immune systems might be compromised, it makes us more susceptible to pneumococcal-based diseases, so that's why I've included it here. So we know why vaccination is important. Each year, there's about 1 billion cases of flu, and the 3 million to 5 million of these are severe. and there's 290,000 to 650,000 deaths annually. There's less annual pneumococcal disease-related cases, but they are more severe, and it causes about 1.6 million deaths a year. And then since December 2019, 760 million cases of COVID have been recorded and 6.9 million deaths have been recorded, although it's thought that the actual numbers are a lot higher. Next slide. So in the UK, there's specific recommendations for who can get vaccinated. So the NHS offers free vaccination for pneumococcal, COVID and flu to people who are over 65 or under 65 and immunocompromised. Free COVID and flu vaccines are also available to people who are carers, healthcare workers, or living with someone who's severely immunocompromised. And all children between the ages of 2 and 17 can get the flu vaccine for free. And young babies are also vaccinated against pneumococcal. Next slide, please. So just to look at our current vaccination uptakes quickly, we can see that older adults who are eligible are engaging in uptake. Last year, we had 79.9% of people over the age of 65 receive the flu vaccine. And 49.1% of immunocompromised individuals that were eligible also got vaccinated. So we've met the World Health Organization's target, which is great. The target is 75% of older adults. Then for pneumococcal coverage, we've got 71.5% of people over the age of 65 vaccinated, and coverage is 46.2% for immunocompromised people. So these numbers look really good, but the problem that we're seeing is that they are decreasing every year. So in 2020, for example, our flu vaccine uptake was 80.9%. And in 2021, it was 82.3%, which was our highest ever. So although these numbers are really high, they are decreasing slightly, which is a slight worry. And that might be linked to some vaccine fatigue that we have been seeing. In terms of COVID this year so far, we've got 92% of people vaccinated against the disease, and 70% of all people over the age of 75 have had a booster in the last few months. The problem we can see with COVID so far is that whilst people over the age of 75 are engaging in boosters really well, younger people aren't, and middle-aged adults also aren't. So last year it was only sorry, my mind's gone blank on the number, but it was only like 26% of people between the age of 50 and 54 that got a booster. So it does decrease quite a lot. Next slide, please. So although our numbers are decreasing, they are pretty good still. So I just want to talk on what we're doing right in the UK. So vaccines are widely available in many locations, including pharmacies. So you can get flu and COVID vaccines at pharmacies. Some pharmacies allow walk-ins, some pharmacies you have to book, but it's a pretty easy process. This is quite important, especially in the UK, as it is currently quite difficult to get GP appointments. So having these extra locations like pharmacies is really helpful. There's also mobile vaccination clinics and vaccine drives in schools and workplaces, that kind of thing. The second positive policy initiative that we have is vaccine reminder systems. So eligible patients who are registered with the NHS will receive emails or text messages when a vaccine is available for them to have. And there's also a call and recall initiative. So after you get this text, if you don't go get your vaccine, someone will check in with you and try to understand sort of why is there a barrier, is there hesitancy, and use that conversation to encourage people to go get their vaccines. There's also birthday cards, which are more used for shingles, but it's still an interesting initiative where you get sent a birthday card when you're of the eligible age to get vaccinated. So that's also a good reminder. And then there's also reminder systems for GPs, so if a patient comes to them with any issue, if they are eligible for a vaccination, they'll get flagged on the system so that at the end of the appointment, the GP can offer a vaccine to them. The next positive is online booking systems. So for any pharmacies that don't take walk-ins, you can book online really easily. I just did this recently myself, and there's no delays, there's no mess ups with the booking or anything, so that works really well. And then for those who are perhaps less mobile or would just struggle to get to a pharmacy or a GP's office, a lot of pharmacies do home visits. Another positive is the NHS's essential service requirements. So to be registered as an NHS pharmacy, they must meet certain requirements, and one of these is healthy living and another is promotion of public health. Vaccination falls under both of these. So offering vaccinations is actually a requirement for a pharmacy to exist as an NHS body. So that's a really good sort of push for pharmacies to invest in vaccination themselves. The next positive is campaigns like Grab a Jab. This was a COVID era campaign in 2020 where marketing was set up with mobile sort of pop-up vaccination clinics at the same time. And this really encouraged COVID uptake, especially for younger people and racial minorities, who were two groups that were slightly slower on their uptake for the vaccine. The next positive is the Making Every... This is focused on healthcare workers, and it's the idea that not everyone's point of contact within the NHS is their GP. So some people might be more likely to use their pharmacy, some people might be seeing a physiotherapist. So there's all sorts of healthcare professionals that we interact with. And the MECC encourages every single healthcare professional to speak to every single one of their patients about vaccination, so we can really get the message out there. And then the last positive is community vaccination champions. So that is where the government, national and local, works with community leaders, influencers, and organizations to encourage uptake of vaccination. And this really, it works, but it also embeds this level of trust within communities, which is really important when it comes to vaccination. Next slide, please. So there's a lot of good things happening. Our vaccine uptake is great, but nothing's perfect. So I thought I'd also touch on what more we could do within policy and practice to improve vaccination, especially for pharmacies. So more free vaccination in pharmacies. You can get flu and COVID for free if you are eligible. You can't get things like pneumococcal or shingles at pharmacies. So to broaden sort of the scope of things that pharmacies could offer would be really useful. And then also more funding. So this sort of links in with the previous point, but it also refers to the NHS's recent decision to limit access to COVID-19 vaccines. So you can't get them in all pharmacies. And if you're of certain age groups, you're no longer eligible for any boosters, even privately. So that's definitely an issue that needs to be solved. The next one is more inclusive and representative campaigns. We know they work, we have them, they just need to be more widespread. So we do have some great examples already. Nadia Hussain from the Great British Bake Off took part in a campaign to encourage British Bangladeshi citizens to get vaccinated against COVID. And we've also seen similar campaigns with Sir Lenny Henry to encourage Black British citizens to get vaccinated. So we have the evidence, but they're just not widespread enough. Then more community collaborations is also key. So we need to integrate ourselves in communities to build trust more. And this, we know this results in higher uptake. And this is especially really important for communities that have previously either been left behind by healthcare or actively oppressed by healthcare. So it's not really simple, and it's understandably difficult for those events to be forgotten. But by integrating ourselves in communities and proving that things are different, we can hopefully build up trust again and ensure that vaccination is safe and uptake is high for all people. Then easier booking systems are also really important. Previous research that I've done has shown that whilst the NHS app on your phone is really, really easy to use, the website is quite difficult. And it actually deters people from booking vaccines altogether if the website booking system is just too hard to navigate. Then the next issue is improved digital health record systems. So a lot of the digital health record systems in the UK are quite outdated. A lot of them also don't sort of talk to each other. So what you might have in a pharmacy would be different from what you have in the GP's office. But the major issue here is that a lot of pharmacists are not able to input patient information into digital health records. So if you do get vaccinated at a pharmacy, it's possible that they'll have to call your GP and send the information over to them, and then the GP can enter it in. And it's just convoluted. It just adds, more work, more stress for all these healthcare professionals who are, in the UK at least, already under quite a lot of strain. So that definitely needs to be improved. Extending the reminder system would also be great to include pharmacies. So it works really well when you get GP reminders, but you can't get a reminder from your pharmacy right now. And if you are registered with a specific community pharmacy, it would be great to utilize that contact too. The next one is improved privacy protection. This has also come up in some of my previous research. When you go to a pharmacy to get vaccinated, if you are getting an NHS vaccination, you have to give them the reason for why you're eligible to have it for free. So it could be any of the reasons that I listed in the previous slides about who's eligible. But it's not private. You sort of stand at a desk and you tell them what's wrong with you or tell them why you're eligible, and there could be people around. There could be, there's no privacy protection in that sense, and that deters quite a lot of people as well. So having some improved privacy protection in pharmacies would be really important. And then the final point that could be done is just extended opening hours. Some pilot programs in the Isle of Wight, where vaccination is generally lower than the rest of the UK. They kept pharmacies open later and also opened them on Sundays, and they saw a really big increase in uptake from this. So that's just some stuff about sort of the UK's vaccination uptake now, what policies work and what policies could be improved. Thank you so much.
Thank you so much for the presentation, Anna. Now we're moving on to our next and last speaker, Leticia Caligares. Leticia has been a clinical pharmacist staff in the University of the Republic, Uruguay between 2006 and 2013. Between 2014 and 2021, she worked in pharmacy division manager at PharmaShop Pharmacy. She specialized in analysis and monitoring of the Uruguayan pharmaceutical market. Starting from 2021 until today, she's been working as the technical director of 2 pharmacies in hospital setting, Ministry of Defense in Uruguay. And also, meanwhile, she is the specialized pharmacist in male and female fertility treatments at CREA Uruguay as well. As the organizational activities, starting from 2021, she has been the professional secretary project implementing immunization service in CP. And also starting from 2022 until today, she has been the secretary of the Pharmaceutical Society of Uruguay. And now she has been serving as the observer at CP Exco in FIP. Dear Leticia, the floor is yours.
Thank you, Ali, for your presentation, and thank you, Luna, for the invitation. Well, I'm going to tell you that here in Uruguay, we're not allowed yet to get the vaccination in community pharmacies, but we have already presented to the Ministry of Health a plan. We have several meetings, and next year we are going to allow to immunize in community pharmacy with the help of nurses. That was the first thing that we have to change in our plan, because the nurses want to be part of the plan. So we say yes, and we are going to go together with the first pilot plan for immunization, for flu immunization in community pharmacy. So after that, I am a member of a community pharmacy section. So first I asked my colleagues to send me some what they do in community pharmacies to get people go there. And here there are some, this is a strategy is from the United States. The new name of the campaign is "A flu vaccine can take flu from wild to a mild." And we have they have done different photos with going to different part of the population. For example, one is for the pregnant woman, one is for the older woman, the older person, sorry. And next, please. Well, next, please. And this is, for example, for South Africa, and they do some flyers with the difference between cold and a flu, and they share in the pharmacy to the people go there and get some information. And next, please. All this information is for free, and you can find in the different associations of the country, and you can download and you take as a part of your material. And next, please. Okay, and this I'm going to stay here. This is a strategy is going up in Spain. They take some photo with the patient and they encourage people to go to get the vaccination. I must say that in Spain it's not allowed that community pharmacy be a vaccinator centers. So they encourage to go to another place to get the vaccine, but they are starting working in community pharmacies doing these kind of actions. I think that if we cannot have a vaccination in our pharmacy, what we can do is to be part of the publicity and be part of saying that educate people with common language to encourage them to go to the pharmacy or any place to get a flu vaccination. In that part, I would say that we can use artificial intelligence to send message to pharmacy users to encourage them to vaccinate against the flu. What we can do with artificial intelligence, for example, we can personalize reminders. We can use a chatbot, or for example, if we have a base with the numbers of our customers, we can send information about the next campaign of any vaccination or for flu, for MMRs, for meningococcal, etc. But it's important that we can segment our audience. For example, we can put all the data in with the artificial intelligence, and we can separate, for example, a specific group, such as older individuals, people with underlying medical condition, for example, diabetes, EPOC, heart disease. And for example, another important group is people who work in healthcare, and send messages tailored to need and concern to each group. We can also have a data analysis. For example, if we have we have dispensed to the people, we have put there, and with the use of artificial intelligence, we can know who is more likely to get vaccinated and who may need additional encouragement. For example, if we know that one person get vaccinated 2 years ago, but not last year, we can encourage he or she to come to get the vaccination. At this point, I think that it's very important for pharmacies to use artificial intelligence ethically and comply with privacy and data protection regulation with collecting and using users' information. Lastly, I will say that it's very important that we as a pharmacist can record in the patient medical in the patient medical records after they receive their flu vaccination. I have listened to my colleagues, and I see that in Australia it can be, but not in the UK. So I think that is very important, and if we here in Uruguay ask to have this power, so we can put in the medical records of the patient that he have or she have the vaccine, flu vaccine. Okay. This I'm going to talk a little about blockchain and what we can do with a system in blockchain to operate the vaccines between the labs and the pharmacies, for example, or the point to get vaccination. Blockchains is a technology that offers transparent, secure, and traceable distribution of vaccines, addressing current limitations. It allows various parties to interact without interference, build trust, and prevent data manipulation. Vaccine distribution, for example, if we have an agenda like they have in Australia and in UK, we can integrate the data in the agenda to the blockchain, and the blockchain is going to send us, for example, if we have 10 people or 100 people in our pharmacy, using the technology, they are going to need to prevent that doses in my pharmacy, and they are going to send us the vaccines. It's also blockchain is also very good, but it's allowed a lot of people write in the layer of information, and we can also for example, a patient goes and have any reaction, red, or some fever, he also can write, and it's going to be in the blockchain, and it's going to facilitate the information between the laboratory and the patient. And of course, is bring the patient a lot of security, because sometimes they are aware of the quality and anything about the vaccine, and all of this information is going to be in a code, and we can access anytime. And I think that this is very high, but we use a kind of blockchain here in Uruguay during COVID. And it was a very, very nice experience. And we use blockchains, and the military help us to distribute in Uruguay. And we have near the 90% of the inhabitants have COVID vaccination, and we take that data to present the Ministry of Health that our plan. So we are happy that next year we are going to have a pilot plan, and maybe I can share with you our experience. Thank you.
Would like to thank all of you. Really, it was very inspiring. Unfortunately, we are running out of time. We cannot have a panel discussion, but I grab the opportunity to thank all the presenters and speakers for their inspiring, for their interesting and informative sessions. I hope the audience will have the opportunity to have ideas and be informed about what they can do in their country. I thank all the team of the FIP. Thank you, Ali, for being with me. And thank you for all the FIP members that are behind the scene. Thank you all pharmacists who attended this afternoon, this morning, this evening, this session. Please do not forget to register if you're not registered yet to the third and last episode of this series. Thank you again and see you soon. Goodbye.